Hello everyone, I'm Dr. Sirisha Prabhakar, third year resident from the Department of Radio Diagnosis at Dr. D.Y. Patil Medical College, Navi Mumbai. Today I'll be taking you on a diagnostic journey through arteriovenous fistula complications in hemodialysis patients using Doppler ultrasound. We'll explore 8 fascinating cases that highlight why early detection is crucial for our dialysis patients. Let me outline 5 main complications we encounter in patients with AV fistulas created for the purpose of hemodialysis. First, being thrombosis, where there is formation of blood clots within the AV fistula that obstruct the blood flow, rendering the fistula unusable for dialysis. Second complication is stenosis, where there is narrowing of the blood vessels within the AV fistula, which can cause reduced blood flow, inadequate dialysis, and eventual thrombosis. Third is aneurysms, where there's abnormal dilatation of the vessel wall, posing risks for rupture and bleeding. Fourth complication is infections, which is less common, but infections can still occur, leading to serious complications. Fifth being the Steele syndrome, in which where there's too much blood diverted through the fistula, depriving the distal limb of adequate circulation and causing ischemic symptoms. Each of these can compromise dialysis effectiveness and require timely intervention. So why this matters? Arteriovenous fistulas are a form of vascular access for hemodialysis, particularly in patients with chronic kidney disease, due to their longevity and lower complication rates, and is quite literally the lifeline for patients with chronic kidney disease. However, they are not without any problems. AV fistulas are, yes, preferred over grafts and catheters, but these complications can render them unusable, making imaging detection through Doppler quite critical. Why is Doppler so valuable for AV fistula assessment? Is first, it's non-invasive, there's no radiation, it is infinitely repeatable and can be done bedside. Second, it provides comprehensive information like flow velocity and direction. Normal flow velocity, which we consider, is 500 to 1500 ml per minute. Second, it can provide us an idea of the vessel diameter and wall thickness, which provides access for cannulation. Then if there's any thrombosis, stenosis, or aneurysm present. Third is broad clinical applications like a preoperative evaluation and fistula mapping to make a fistula in the patient to find the or choose the best site for preoperative vessel mapping, post-operative monitoring of and fistula maturation to ensure there's proper maturation and functioning of the fistula. So our study included patients with clinical history of CKD. Inclusion criteria was evaluation of any patient who comes with AV fistulas created for hemodialysis. Exclusion criteria were patients with congenital AV fistulas, iatrogenic AV fistula, post-infective, post-traumatic AV fistula. Today, I'll be sharing 8 compelling cases demonstrating these complications. Each case taught us something valuable about the power of Doppler imaging. So the first case was a 47-year-old male patient, CKD, on hemodialysis since 2 years. There was a left radiocephalic fistula. Patient presented with cessation of thrill over the fistula site, difficulty in cannulation during the last dialysis session. So when a Doppler was done, we found echogenic material in the antecubital vein, which was non-compressible and no color flow was seen, which we came to the conclusion that it was suggestive of thrombosis. So the take-home message from this case was loss of thrill is an emergency. This fistula was completely thrombosed and unusable. Without alternative access, this patient couldn't receive dialysis. The second case was a 48-year-old female patient, CKD secondary to diabetes, on dialysis with a right brachiocephalic fistula created 1 year ago. Patient presented with visible swelling at the fistula site, pain during dialysis, and prolonged bleeding during or post cannulation. So when we did a Doppler ultrasound, we found that the cephalic vein, cephalad to the site of the fistula, was dilated and tortuous in course with increased echogenicity of fat along its walls. And there was multiple dilatations along the course of the cephalic vein. And when we put the Doppler, we found out that there was turbulent color flow seen across the fistula site. Then our third case was a 60-year-old male patient, CKD due to hypertension on dialysis with a left radiocephalic fistula created 1.5 years ago. Clinically, there was weak thrill, high venous pressure during dialysis, and reduced dialysis adequacy. When we did our Doppler, we identified There was a stenosis at the fistula site, and the velocity, the TA max, was 176 centimeters per second. And we saw that there was stenosis at the fistula site with lack of maturation. Distal radial artery beyond the fistula shows evidence of retrograde flow, while the entire ulnar artery showed normal antegrade flow with high velocity and low resistant waveforms. So this was the third case which demonstrated the complication of stenosis of the fistula. The key point from this case was this fistula never properly matured due to stenosis. Early detection could have allowed intervention before permanent damage can occur. Then the fourth case was a 47-year-old female, CKD stage 5 on dialysis. Patient had a left brachiocephalic fistula created 8 months ago. Clinical presentation was swelling and bruising at the cannulation site, pain and no audible bruit present. So when we did a Doppler, or rather a USG, we found a densely hyperechoic collection with few hypoechoic foci in the subcutaneous plane measuring approximately 1.3 cc superficial to the site of superficial to the site of fistula, which was suggestive of a hematoma. However, the underlying brachiocephalic fistula showed normal patency with turbulent high flow velocity with a TA max of 539 centimeter per second. This hematoma was not significant enough to cause compression of the underlying vessels, but however, this is one of the complications of AV fistulas is a post-fistula hematoma formation. The fifth case was a 54-year-old female, CKD due to diabetic nephropathy, recently initiated on dialysis, with a left radiocephalic fistula created 3 months ago. Clinical presentation, the fistula was not palpable, weak thrill, unable to use for dialysis. So when a Doppler was done, we found that there was a non-functioning brachiocephalic fistula with low velocity flow seen across the fistula and the draining vein. The flow volume rate was approximately 156.2 ml per minute. While I told earlier the normal flow rate should be around 500 to 1500 ml per minute. Then the sixth case was a 47-year-old male, CKD on dialysis for 2 years, left radiocephalic fistula created 2 years ago. Clinical presentation was hardening around fistula site, difficulty in cannulation, and reduced thrill. This case can also be called double trouble. I can tell you why. When we did USG Doppler, we found a 5.1 into 1.6 into 2.5 centimeter hypoechoic area, superficial and distal to the fistula site, which on color Doppler showed characteristic yin-yang pattern with it. The appearances were consistent with a venous pseudoaneurysm. Unfortunately, I could not put up the color Doppler images. The vein distal to the above-mentioned area of venous pseudoaneurysm was non-compressible and appeared dilated and showed echogenic material, as we can see here, throughout its course distally, suggestive of superficial thrombophlebitis. So this case was an example to show that in patients with AV fistulas, multiple complications can coexist, and this teaches us to always perform comprehensive evaluation beyond the immediate fistula site. One problem often leads to another downstream. Moving on to the seventh case, a 72-year-old male, CKD on dialysis for 4 years with a left radiocephalic fistula created 3.5 years ago, came with coldness, numbness, and pain in the left hand and reduced thrill. So here's where it gets interesting. When we did a Doppler, we saw that the flow volume across the fistula site was 531 ml per minute, which was a good flow. But we also found a circumferential plaque causing 60 to 70% luminal compromise over a segment of 1.6 centimeter. Even with adequate overall flow, significant stenosis can cause symptoms and requires intervention. And this patient was suspected to be developing Steele syndrome despite seemingly adequate flow. The final case was a 52-year-old male, CKD stage 4 on dialysis for 3 years, came with right brachiobasilic fistula, created 3 years ago. His clinical presentation was arm edema, skin discoloration, and dilated superficial veins. So when we did a Doppler, we found that there is normal patency of the brachiobasilic fistula with turbulent high velocity flow across the fistula and the draining vein. The flow volume was 3.3 liters per minute. The basilic vein, 5 centimeters distal to the fistula site, showed evidence of echogenic material along its posterior wall, causing 10 to 20% luminal compromise, which was suggestive of thrombophlebitis. The cephalic vein was partially compressible with evidence of echogenic material. So the conclusion or the take-home message from this study was, number one, we need to monitor actively, where physical examination plus routine Doppler surveillance will help prevent such complications. Number two, we need to know the red flags clinically, like loss of thrill, weak pulse, limb symptoms, and our emergencies. Number three, early intervention matters. Stenosis greater than 50% often needs treatment before it progresses to thrombosis. And number four is comprehensive assessment. Always check the fistula circuit, not just the anastomosis. So, knowledge about these complications should contribute to the timely detection and allow measures to be taken that might prevent consequences that range from loss of vascular access to serious morbidity and may ultimately be fatal. Both the patient and professional should give utmost care for the AV fistula to reduce the complication. We need to remember one thing while we are assessing patients with AV fistula is the AV fistula is the patient's lifeline, and our job is to keep it flowing. These were the references that I used for this study. Thank you.